Thank you, Mark, for your thoughts on the TAILOR trial, which I think are very legitimate concerns, both for the lack of crossover and the oddity of 4 or 5% complete response rate that is all but unprecedented, as well as the significant gulf between patients who pursued the trial and patients who ended up on the trial. One of the questions that someone asks is whether there might be any other trials out there to address this question, given the inconsistency between the TAILOR results, interest, and some other work. And if not, I'll ask either of you for your impressions of what do you think this will mean in terms of clinical practice, at least in the United States, for selecting chemo over erlotinib in wild-type patients, or whether people will abandon Tarceva for EGFR wild-type because of it.
My sense is that TAILOR remains an outlier. The data, in my opinion, was a bit premature. Most often, when you have a phase 3 trial, you report on the primary endpoint, not necessarily just the secondary endpoint. So I think this is a bit premature, and I think we have to be careful. Other data sets, whether you look at the trials I mentioned, another thing that I didn't mention in the presentation was certainly we know from the Saturn data that this is an active agent in EGFR wild-type patients. Obviously, Saturn was against placebo, not against another cytotoxic. But at least from my personal view, I don't think it should influence. I think we should wait for more data before we let that seep into our decision-making part of seeing patients and recommending what we think. My personal feeling is that if you look at these agents that were in TAILOR, docetaxel, and erlotinib, patients should have a shot at both of them, whether it's second or third line. We know these are active agents. Part of our mantra of treating this disease now is that we attempt to get multiple lines of therapy in over time, in that we don't have good prospective markers of treatment benefit, and that it's hard to look at a patient, whether you look at clinical factors or biomarker factors, to say, I'm going to exclude this patient from treatment from drug X or drug Y based upon these sorts of things. I think everyone needs a shot. I'm not quite sure how TAILOR helps us in that sort of thinking. I will admit that erlotinib has a second and third line indication. I still think it's a very reasonable second line choice. But if you choose not to use it in second line, it should be your third line option in a wild type population.
I think the question is, if we look back to BR21, erlotinib was approved in the second and the third line setting, and even though the mutation data from BR21 are somewhat unclear, Saturn gave us a little bit more data to show that it did appear effective as a switch maintenance therapy regardless of EGFR mutation status. So if anything, I think it underscores that patients with tumors with EGFR mutations should have erlotinib or an EGFR TKI on the first, or maybe the switch maintenance setting, or maybe second line. And patients without EGFR mutant tumors, maybe we'll consider it second line or third line, maybe in the switch maintenance setting. But it's not a question of if, but sequencing.
Exactly, when.
Another question was with regard to the SELECT trial and work along those lines, about any other work that was presented at ASCO or outside of it on targeted therapies in the adjuvant setting. I know of the RADIANT trial that you alluded to in passing, Joel, but that's still at least a year or two away. There's nothing else out there just yet that we can speak to, is there?
Right. With regard to EGFR TKIs in the adjuvant setting, nobody knows exactly when RADIANT will be out and reported for the primary endpoint, and other things like overall survival could be a few more years after that. So there are no data in this setting, which is why it was interesting to see at least some effect in delaying the development of the metastatic disease in this patient population. Were you asking about other adjuvant therapies in general, or targeted adjuvant therapies?
Either way, probably broader than just EGFR.
Yeah, there's discussions, of course, thinking about adjuvant therapies, crizotinib, for example, and ALK-positive non-small cell lung cancer, but I don't think these clinical trials are open yet. They're still in development. So we'll look for them. As soon as an effective agent is seen, the usual oncology practice is to prove it in the stage 4 setting and then move it into the adjuvant setting. So I think erlotinib is very similar to imatinib in GIST tumors, where it looks like indefinite treatment is a possibility to keep the micrometastatic disease at bay. I think we have to look to other solid tumors to find analogies. I haven't seen anything in the lung cancer field.
Thank you. I wanted to turn to the SELECT trial that you'd mentioned, or the one with adjuvant erlotinib, and it is striking that the recurrences really seem to occur beyond the 2 years. Do you have a sense of where this might go in terms of the need for indefinite EGFR TKI therapy? And maybe to be more direct, do you have any sense of whether any or all of the investigators would recommend this outside of a clinical trial for patients without an endpoint to the treatment?
As of now, I as an investigator, and I've asked other investigators, we probably would not recommend this outside of a clinical trial. It depends on the clinical scenario, though, because a patient with stage 3A and a large bulk of disease may have a very different risk of recurrence than a patient with a stage 1A lung nodule that was resected. One thing to keep in mind is, despite treatment with the adjuvant erlotinib, a lot of these patients had recurrences in solitary sites that with or without the adjuvant erlotinib may have still had the solitary site of recurrence and were treated with local and definitive therapies. So as of right now, we don't know, is the overall survival going to be significantly different? Is it going to be altered by just the minimal 2 years that patients were on this treatment? Or is it going to be altered by even more than that, i.e., are we actually curing or killing micrometastatic disease instead of delaying it? But we don't see resistance, so I don't think we're fueling the micrometastatic disease, which was one of the concerns from the Canadian BR19 trial of adjuvant gefitinib. And everybody said after BR19, it may be concerning to conduct this sort of trial. So as of right now, with BR19 and that unknown, radiant unreported, and this trial hitting its primary endpoint but being expanded and markedly small by comparison, I wouldn't recommend this outside of a clinical trial. But, of course, on a patient-by-patient basis, there may be a high risk of recurrence and it might make sense. As far as the duration of therapy, that will have to be answered in other prospective clinical trials. My analogy for this is tamoxifen for breast cancer, where a few years is okay, more years is probably better, and it's hard to conduct the trials all at once to determine how long and whether it works. So those will be follow-up trials if we find absolute benefit on the RADIANT trial. The RADIANT trial did have 120 patients with EGFR mutant lung cancer, 40 of whom are on placebo, 80 of whom are getting treatment. So we may be able to look at those data to get a sense of whether this is effective in addition to the full 100 from this trial on the SELECT.
Mark, what were your thoughts when you integrate the SELECT trial results with the BR19 results of gefitinib? Is there some concern that we should have that patients may rebound with recurrences after discontinuing EGFR TKI therapy?
Yeah, I think that is a concern, and I was going to bring up the tamoxifen analogy that Joel just brought up in terms of longer may be better, and the question is how long, and how does the biology change if you don't do it long enough? The criticism of the BR19 was that the median duration of treatment was about 6 months, and that may not be enough, and it may select certain clones that have a more aggressive biologic behavior, and that may have accounted for the observation of suggested detriment in BR19 as a result of adjuvant gefitinib in the mutant population. So outside of a clinical trial, I've not been recommending it, and I've advised community docs that I talk to or call me about this not to do it. I still think it remains investigational. I do agree with Joel. Maybe we will get a signal from RADIANT. There's at least one European trial and some talk in the U.S. of doing an EGFR mutant adjuvant trial. Obviously, the difficulty with that is that obviously that date is years away at this point. So I think we're going to be stuck with this question for quite some time unless RADIANT in the 120 patients or so gives us a clear signal one way or the other. But I don't know that it will with just 120 patients.
We may see some data from Asia as well, more single-arm trials like this, or single-arm versus adjuvant chemotherapy. So those trials are ongoing and haven't been reported yet. But we don't have to just look at the Western population necessarily. We may get some signals from the other trials as well.
Right.
And in fact, often with the EGFR-based therapies, we've had the pace set by Japan or China, and plus a few institutions in the U.S. that are looking at this in particular. So weekly irinotecan looked pretty unfavorable as a second-line therapy for small cell lung cancer. Would you, Mark, say that that was a takeaway of this? I'll admit that I've been somebody who has used that based on the difficulty of the 5-day conventional schedule, but I'm impressed by the disappointing results of the backbone regimen.
Yeah, again, remember, topotecan is approved in sensitive relapse patients only. This was a refractory population. I think even historically, the response even with topotecan in that population have been low. When I see patients in this setting, I recommend topotecan. I think there's an advantage to having an oral form of this drug, and it's a lot easier to give 5 days of oral topotecan than IV topotecan, so that's what I do. I've not done the weekly regimen. I agree with you. Certainly there was no signal in this trial that we should look favorably at weekly topotecan at this particular point. Admittedly, it was a bit less toxic than we're used to seeing, but we don't have a head-to-head comparison, so we don't really know. And I think toxicity, obviously, mostly hematologic, can be controlled with appropriate dosing of patients in this setting. So I agree with you. I think you were kind of saying that there didn't seem to be any signal there with regard to perhaps a more convenient schedule of this agent. But again, this was, as I mentioned initially, a refractory population, not a sensitive population.
Joel had mentioned the LUX-Lung trial, which I agree was one of the more anticipated trials heading into ASCO. We saw progression-free survival of 13 plus months. We did not see overall survival, and really the question I think we face is if the drug is approved for EGFR mutation positive patients in the first-line setting, it does appear clearly more toxic. I'll start with Mark, but I'll come back to Joel about whether you think that anything we've seen makes you believe that this is a more effective agent than drugs we have now, particularly erlotinib in the U.S., or Tarceva, for EGFR mutation-positive patients. And even if it is the toxicity more than counterbalancing that?
This was a long-awaited data presentation. To be honest with you, I was a bit underwhelmed by it. It didn't necessarily look any better than the 6 other trials that we've seen that were either mutation-specific or had mutations measured like IPAS and Signal. So I wasn't overly impressed with the efficacy data. I was impressed with the toxicity data. I mean, the rates of grade 3-4 rash and diarrhea were notably higher than we typically accept with erlotinib. Part of it may be a dosing issue. Many of us are sensitive to the fact that perhaps in EGFR mutation-positive patients, strategy of maximum tolerated dose may not necessarily be the best strategy in all patients. So perhaps you could get away with less toxicity with this agent, but presumably you wouldn't necessarily see any better efficacy in this population. As Joel pointed out, it's time that we see some comparative data between these agents, and we have LUX-Lung 7 out there. I don't know the timeline for that. Does anyone know the timeline for that reporting out?
I don't. I guess the question is, if afatinib is approved in 6 months or something, would you be inclined to write for that or for Tarceva for your patient who you find out has an activating mutation?
What would make me change, to be honest with you, would be if it were cheaper for the patient.
And from my perspective, what would make the difference is if it could be prescribed off-label together with cetuximab. That's the difference. As a first-line treatment, it does look more toxic. And I didn't have the opportunity to prescribe or give on clinical trials gefitinib very often, but talking to people who did, gefitinib is an easier drug than erlotinib, and it looks like erlotinib is an easier drug than afatinib. And part of this is about improving quality of life. So if there's something potentially available that can rescue patients who have acquired resistance, or if we continue erlotinib past the point of progression, which we did see some data on, that looks like an effective strategy even after this point of progression that we saw in the LUX-Lung 3 trial. Maybe patients who are on erlotinib may have progressed, but progressed fairly slowly. So there might not be an overall survival difference between the two agents that work the same way. So I don't think I would be very excited about prescribing afatinib given the increase in toxicity without more data.
But I do agree with Joel. Having another EGFR TKI, we won't have the competition discussion in the first-line setting, but in selected patients where you could use it in combination with cetuximab, another approved agent, it may be a battle with individual insurance covers, but certainly a battle worth fighting in selected patients, I believe.
Just one last question, and that's on Rogerio Lillenbaum's trial of performance status 2 patients and doublet versus single agent. My sense is that there has still been a lot of wariness about giving doublet therapy to patients who are in that marginal performance status range, at least heading into ASCO, and despite the CALGB data and other things, and as well as work on elderly, regardless of performance status. So, practically speaking, moving forward, what do the results mean? Is it enough to just end that argument and try to compel people that get over this, we should all be using doublets? Is there still enough of an individualized approach that it is not something that we should say is the clear standard of care, or is this still an open question?
No, treatment has to be individualized. That's the role of the medical oncologist and the reason that we have to see patients and evaluate them and answer one of the key questions that Mark brought up at the beginning of that discussion, which was, is the patient's bad performance status from the tumor, or is it from everything else that's been going on before? And if it's from everything else that's been going on, their performance status is not going to improve from doublet chemotherapy, and their quality of life probably won't either. But if their performance status is bad from the tumor, you may want all the response possible, and doublet chemotherapy may make sense. So I think this is a continuation of the argument of who gets switch maintenance therapy and who shouldn't, and instead it's in the frontline setting of who should get one drug and who should get two. We still have to decide for every patient on an individual level whether two drugs is appropriate, one drug is appropriate, or no drugs are appropriate, and what's going to help the patient most.
I think Joel said it eloquently. I often tell our fellows, if you talk to a patient and you get the sense that 2 years ago, because of comorbidities, their performance status was borderline, you're not going to help them with two drugs. You're probably going to hurt them. But if you have a patient who 3 months ago was fully active and now is diagnosed with stage 4 lung cancer, and it tends to be aggressive cancer patient comes in and has mostly disease-related symptoms, they don't have substantial other comorbidities, I've kind of been doing that since the results of the CLGB trial. So this didn't really necessarily change anything that I'm going to be doing. It kind of just reinforces that judgment. And this is a population where you can be too aggressive, and you probably shouldn't in those patients because you can cause more toxicity with two drugs versus one. But certainly it does support that if your assessment is that the performance status is disease-related, you should be more aggressive. Now, we have to admit that we don't have good tools for establishing this. It goes back to the old art of medicine and good clinical judgment and having a lot of experience treating these patients and making the right call with the right patient. But that's what we do as oncologists. I think we shouldn't shy away from the borderline performance status patient of being a bit more aggressive, and this kind of reinforces that.
My practice is to give platinum-based therapy whenever possible and not necessarily select just based on performance status or age or other single factors like that. And we can't forget about the role for supportive care, palliative care, continuing whether or not patients are getting chemotherapy, because that's essential in helping people feel better.
If afatinib is commercially available, would you then be inclined to pursue afatinib and cetuximab outside of a trial for many, most, all of your patients with acquired resistance, or would you really relegate that to clinical trial setting?
I always put a good clinical trial first, but many patients may not have that available to them, so I would say outside of a clinical trial, or if a clinical trial wasn't available, if afatinib was around, I would try to pursue it in most patients.
I would too. If a clinical trial wasn't available that was directed against the molecular mechanism of resistance, then I would try to get it.
Well, thank you both very much. I really want to thank Drs. Joel Neal and Mark Socinski for preparing everything for today and giving us so much thoughtful commentary on some tough topics. I also want to thank our partner with Grace Longevity Foundation for sponsoring this, and for everyone who joined us and stuck around, judging from the many questions that came in and so many people still here an hour and a half later. I know it was as interesting for you all as it was for us.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.